Okay, let's unpack the information you've put in front of us today. We are diving deep into a topic that might sound technical, but it's incredibly important to understand because it's often silent. Abdominal aortic aneurysms, or AAAs.
That's right. Our goal here is to really cut through the medical jargon and get to the absolutely critical information from the material you've shared.
hmm
The key definitions, the surprising facts, why they happen, and importantly, what's done about them.
And getting a handle on this is vital. These aren't always obvious conditions, and as we'll see, finding them before they cause a major problem makes, well, all the difference in the world. This deep dive could genuinely be impactful, not just for you listening, but maybe for people you care about too. So let's start right at the beginning. When we talk about an aneurysm, what exactly is that?
Okay, at its core, an aneurysm is a permanent localized dilation of an artery. Think of it like a specific spot on an artery wall that is weakened and started to balloon outwards.
Like a bulge in a garden hose, maybe?
Precisely. A really good analogy. And it's not just any bulge. To be technically classified as an aneurysm, the artery has to increase in diameter by more than 50%, or measure at least 1.5 times its normal size.
50%, that's significant.
It is. And what's considered normal varies, depending on factors like age, sex, even blood pressure. But that dilation threshold, that 1.5 times normal, that's the key marker.
Okay, a significant permanent stretching. And today, our focus is specifically on abdominal aortic aneurysms, AAAs, which, as you said, are the most common type mentioned here. Now, the aorta, that's the body's main artery, right? Starts right from the heart. Can you sort of guide us on its path and where these AAAs are most likely to pop up?
Absolutely. So the aorta leaves the heart, makes an arch back through the chest, and then descends, runs down through your body, sitting primarily towards the back.
Okay.
It goes all the way down through the abdomen until it splits into the two iliac arteries that supply blood to the legs, roughly around your belly button level, maybe a bit lower.
And I remember reading it actually changes size as it goes down, narrows a bit.
It does, yeah.
Oh,
In an adult, the aorta is normally about 2 centimeters or roughly 3/4 of an inch wide, up high in the abdomen, say at the level of the celiac artery.
right.
And while aneurysms can occur anywhere along the aorta, like in the chest, the thoracic aorta, which accounts for maybe 12%, according to this source, the vast majority, or really striking 80%, occur in the infrarenal abdominal aorta,
Infrarenal meaning?
meaning the section below where the arteries branch off to the kidneys. That's the real hotspot for AAAs and where our focus will largely be today.
So mostly down low in the abdomen, that's where the stretching tends to happen, which of course leads us to the big question, why? Why do these happen? We used to hear a lot about hardening of the arteries, atherosclerosis. Is that still the main story?
Atherosclerosis, that plaque buildup, it certainly plays a role in weakening artery walls, and it's often present in patients with AAAs. But the more current understanding, the picture emerging from this material, is that it's not just a plumbing issue related to atherosclerosis. There's more going on.
Oh, interesting. So what else is involved then?
Well, there seems to be a significant component of genetic predisposition, a familial tendency. It's actually quite notable. The sources say between 15% and 25% of patients undergoing AAA repair have a first-degree relative, a parent, sibling, or child who also had a clinically apparent AAA.
15 to 25%. Wow.
Yeah, there's clear evidence these tend to cluster in families. Think about that case study example, AL. She had a strong family history, right? Both her aunt and possibly her mother were affected. That's a classic picture we see.
Okay, so genetics is a big piece. And I think I saw something about enzymes actually breaking down the artery wall.
Yes, that's a key part of this newer understanding. Enzymes called matrix metalloproteins, or MMPs, they seem to play a really damaging role. They essentially break down essential components of the aortic wall's structure, things like elastin and collagen.
The stuff that gives it strength.
Exactly, the stuff that gives the artery its strength and flexibility. When those components get broken down, the wall weakens, it loses integrity, and it begins to dilate or stretch.
So it's like the building blocks of the wall are being actively eroded.
That's a good way to put it. And current theory suggests inflammation is involved in this process in pretty much all AAAs. And this connects really strongly back to smoking, which is one of the most powerful risk factors.
Ah, the smoking link.
Yeah, byproducts from smoking are directly destructive to the aortic wall. They actually increase the activity of those damaging enzymes, particularly one called elastase, which, as the name suggests, targets elastin.
So smoking is actively attacking the very structure of the artery wall. That makes the link crystal clear. What are the other major risk factors we need to be aware of from these sources?
Okay, so beyond smoking and family history, the key risk factors really stack up. First, gender. Males are significantly more likely, the sources say 3 to 6 times more likely to develop in AAA than females. It's actually present in over 5% of older men who've smoked.
3 to 6 times, wow.
Yeah. Then age. This is definitely a condition associated with aging. Prevalence climbs sharply with age, peaking between 70 and 80 years old. And the stats are pretty stark. 95% of patients who die from a ruptured AAA are over 65.
Okay.
Smoking. We've covered why, but it bears repeating. Smokers are 3 to 5 times more likely to develop in AAA. And interestingly, often the length of time someone has smoked is even more critical than the sheer amount per day.
Duration matters more than quantity sometimes?
It seems that way, yeah.
Yeah.
Then hypertension. High blood pressure puts constant stress on the artery wall. It accelerates that degenerative process and, importantly, increases the pressure on an already weakened wall, significantly raising the risk of rupture.
Makes sense.
Family history. Again, worth reinforcing. Having a brother treated for an AAA, for example, means you have a fourfold increased risk yourself. It's a major predictor. This is exactly why AL's concern about our children is so relevant.
Right.
Also, the presence of aneurysms elsewhere. If you have an aneurysm in one spot, you're at higher risk of having or developing them in other places. For instance, someone with an aneurysm in one popliteal artery, that's behind the knee,
Okay.
has an 8% chance of having a AAA. If they have popliteal aneurysms in both legs, that jumps way up to 30%. And if you have a AAA, you have about a 12% chance of also having a thoracic aortic aneurysm up in your chest.
So they can cluster.
They can. And finally, certain connective tissue diseases like Marfan syndrome and Ehlers-Danlos syndrome also increase risk, though those are less common overall.
That's a really comprehensive list. It paints a clear picture of who is most susceptible. Now let's get to what is arguably the most critical danger associated with AAA's rupture.
Yeah, this is where the physics unfortunately gets pretty grim. There's a principle in physics called the law of Laplace, which basically tells us that the tension or the stress on the wall of a sphere or cylinder like an aneurysm increases as its radius, its size, increases.
So bigger means more stress on the wall.
Exactly. A bigger aneurysm wall is under dramatically more stress, making it far, far more prone to tearing and rupturing.
So size is really the enemy here.
Absolutely. The data is crystal clear on this. Size is the single most important risk factor for rupture. I mean, look at these numbers in the material. They're quite striking. For AAAs less than 5.5 centimeters, the rupture rate is relatively low, about 1% per year. This is why observation is usually the approach for smaller ones.
Okay, 1% per year. Manageable risk, maybe.
Right. But when they grow to between 5.5 and 6.9 centimeters, the rupture rate just explodes, jumps up to 9.4% to 10.2% per year.
Wow, that's a huge jump, from 1% to almost 10%.
It's massive. And that's why prompt repair is typically recommended once they reach that size range. And then, for AAAs greater than 7 centimeters, the rupture rate is, frankly, terrifying. 32.5% in just 6 months.
32% in 6 months, that's urgent.
Extremely urgent. These require intervention very quickly.
And there was a nuance mentioned about size and gender, too, wasn't there? Something about women.
Yes, that's an important detail that's emerging. Women may have a slightly lower threshold for rupture. Their risk might increase significantly at a size closer to 5 centimeters compared to maybe closer to 6 centimeters or 5.5 to 6 for men. So the size recommendation for repair can sometimes be adjusted based on gender. That might have been a factor in AL's case at 5.8 centimeters.
Okay. And the outcome, if one does rupture?
A ruptured AAA is a true medical catastrophe. The overall mortality rate is incredibly high. The sources cite anywhere from 71% to 77%. That includes deaths both before reaching the hospital and in the hospital.
70 to 80% mortality.
Yeah. Now, contrast that with the mortality rate for an elective surgical repair, one that's done before rupture. That rate is much, much lower, only 2% to 6%.
2 to 6% versus over 70%.
Exactly. That dramatic difference is precisely why finding and fixing these before they rupture is the absolute primary goal of screening and management.
Given that really frightening outcome of rupture, how are these AAAs typically discovered if, as you said, they're often silent? Are there any symptoms?
That is such a critical point. AAAs are very frequently asymptomatic. You often don't feel them growing at all. They're commonly found incidentally, just by chance, during imaging tests done for completely unrelated reasons like investigating persistent back pain, maybe looking for kidney stones, things like that.
So you just stumble upon them?
Often, yes. Pain, if it occurs, is usually a late sign. It often indicates rapid expansion of the aneurysm, or, tragically, that a rupture is imminent or has already happened.
So you might not know you have one unless someone specifically looks for it or gets lucky finding it.
That's often the case. A physical exam might sometimes reveal a palpable, pulsing mass in the abdomen, especially if the aneurysm is large or the person is quite thin, but it's really not reliable enough as a general screening tool. Its sensitivity is only moderate overall.
Okay, so exams aren't enough. What are the tests used then for finding them or diagnosing them more definitively?
Non-invasive imaging is absolutely key here. For screening, the workhorse is abdominal ultrasound. It's non-invasive, no radiation, no needles generally. It's highly accurate. The sources say up to 95% accurate with an experienced technician. It's relatively inexpensive, and it's excellent not just for finding them initially, but also for monitoring their size over time.
And there are specific recommendations for who should be screened with that ultrasound, right? This seems super important for people listening.
Absolutely crucial takeaway. Based on the information you shared, the screening guidelines generally recommend a one-time screening ultrasound for all men aged 60 to 75 years old who have ever smoked, even just one cigarette. Also screening for men starting at age 55 if they have a family history of AAA. For women, ultrasound screening is recommended for those 65 years and older who have smoked or have a positive family history. And specifically addressing that familial risk we talked about, screening is recommended for men aged 60 to 85 or older who are the siblings or offspring sons or brothers of patients with a known AAA.
That directly applies to AL's kids.
Exactly. Her situation and her concern for her children highlight why these guidelines exist.
Those guidelines are incredibly valuable. Now, if an AAA is suspected or found on ultrasound and they need more detailed information, maybe for planning surgery, what other imaging is used?
Right, that's when tests like CT scans or MRAs often come into play. A CT scan is generally considered more precise for measuring the exact size. And, critically, it shows the aneurysm's relationship to other major arteries nearby, like the renal arteries going to the kidneys. That anatomical detail is vital for surgical planning. It's also the best test if a rupture is suspected, as it's better at identifying bleeding.
But downsides?
Downsides include using radiation, and it often requires IV contrast dye, which means you need to be cautious in patients with kidney problems. Then there's MRA, magnetic resonance angiography. It gives great multiplanar images without using ionizing radiation. However, it has its own limitations. Patients need to lie still in a scanner, which can be tough with claustrophobia. There can be issues with metal implants, and again, caution is needed with the contrast agent in patients with kidney disease. It's also not really suitable for someone who's unstable or needs a quick diagnosis.
Okay. And arteriography?
Arteriography is sort of the traditional gold standard for getting a detailed map of the entire arterial tree and any blockages within it. But it's an invasive procedure involves threading catheters up through arteries, injecting contrast dye directly. It's not typically needed just to diagnose an AAA itself unless there are other specific complex arterial problems they need to evaluate at the same time.
Okay, so diagnosis confirms, yep, there's a bulge there, an aneurysm. What are the options then? Is it always surgery or sometimes just watching it?
For smaller aneurysms, generally those less than 5.5 centimeters, the standard approach is actually non-operative management, which basically means careful observation.
So you just monitor it, keep an eye on it.
Exactly. With regular follow-up imaging, usually ultrasound, maybe every 6 months or once a year depending on the size, to track its size and how fast it might be growing. And it's really crucial for people to understand that based on the current information provided here, there's no proven medical treatment, no pill or injection that can reliably shrink an aneurysm or stop its growth once it's started.
Nothing to directly fix the weakened wall itself with medicine?
Not reliably, no. Research is ongoing, looking into potential roles for medications like beta blockers, certain enzyme inhibitors like MMP inhibitors, and statins, but nothing's panned out as a definitive treatment for the aneurysm itself yet. However, while you're watching it, aggressive management of risk factors is absolutely paramount.
Right, the things we listed earlier.
Exactly. Controlling blood pressure really well, managing cholesterol and diabetes if they're present, and most importantly, absolute smoking cessation. These don't shrink the aneurysm, but they improve overall vascular health and might potentially slow down the rate of expansion.
Okay, so you manage the patient's overall health while keeping a close eye on the aneurysm's size. When does the conversation shift to needing something more definitive, like a repair?
That's when we start seriously considering operative or surgical management. This becomes the standard of care for aneurysms that reach that critical size threshold, generally over 5.5 centimeters, maybe slightly smaller, around 5 centimeters in women because of that potentially lower rupture risk we discussed.
So size is the main trigger.
Size is the main trigger, yes. But it's also indicated for aneurysms that are causing symptoms, like pain, or those that are growing very rapidly, say, more than half a centimeter in 6 months or a centimeter in a year. Or if there's a complication, like a clot forming inside that breaks off and causes blockages downstream in the legs. The entire point, always, is to intervene and fix it before it ruptures.
And what are the main ways they actually do that repair?
There are two primary approaches described in the materials. The traditional method is open aneurysmectomy. This has been the standard for a long time, done successfully since the 1950s. It's major surgery, usually involving a significant incision in the abdomen, sometimes the flank. The surgeon temporarily clamps the aorta above and below the aneurysm, opens up the aneurysm sac, cleans out any blood clot or debris inside, and then sews in a synthetic graft, basically a durable fabric tube, sometimes Y-shaped if it extends down to replace the weakened section of the artery.
Okay, the traditional big operation. Pros and cons.
Well, the big upside is durability. It's a very robust repair, often lasts a lifetime, and typically doesn't require a huge amount of long-term follow-up of the graft itself. The downside, though, is that it is major surgery. It carries significant potential for complications. The sources mention a morbidity rate around 32.4%. It requires the patient to be in reasonably good health, good heart and lung function, to tolerate the stress of the procedure. It involves a longer hospital stay and a much longer recovery time, often 4 to 6 weeks before feeling back to normal. And the mortality rate, while much lower than rupture, is generally higher than the less invasive option.
Which is?
Endovascular Stent Graft Repair, or EVA. This has really gained prominence and, according to the sources, now accounts for over half of AAA repairs in the U.S. It's much less invasive.
How does that work?
Instead of a large incision, surgeons make small cuts, usually in the groin area. Using catheters and guided by X-ray imaging, they thread a collapsed stent graft up inside the aorta to the level of the aneurysm. This stent graft is essentially a fabric tube supported by a metal scaffold or frame. Once it's in the right position, it's deployed or opened up inside the aneurysm. It creates a new sealed channel for blood flow through the aneurysm, effectively lining it and excluding the weakened sac from blood pressure. The blood flows through the graft, not pushing on the fragile outer wall anymore.
Ah, so it relines the pipe from the inside.
Exactly. The advantages are pretty clear. It's much less invasive, uses smaller incisions, can often be done with regional anesthesia instead of general, leads to a shorter hospital stay, maybe just 1 to 3 days typically, and a much quicker recovery, often back to light activities in just 7 to 10 days.
That sounds much better. What are the catches?
Well, there are a few key ones. First, it depends heavily on the patient's specific aortic anatomy, being suitable to shape and size of the aorta above and below the aneurysm. And the iliac arteries in the legs, where the device anchors, have to fit the available stent grafts. Second, there are potential complications early on, like damage to the access arteries during insertion, or blood clots forming on the device, or pieces breaking off and traveling downstream, embolization. But the most crucial difference, the really big one compared to open repair, is the absolute requirement for lifelong follow-up with imaging.
Lifelong follow-up. That sounds like a major commitment. Why is that so necessary after EVA?
It comes down to the most common complications specific to EVA, occurring in roughly 10% of cases, according to this material. It's called an endoleak.
An endoleak? What exactly is that? A leak in place something's not sealed.
Precisely. Remember how the stent graft is supposed to create a new channel and seal off the aneurysm sac from blood flow and pressure? An endoleak is when blood finds a way to continue flowing into that aneurysm sac, but outside of the stent graft itself.
So blood is still getting into the weakened sac. But isn't the whole point to stop that?
Exactly. If blood is still leaking into the sac, that means the sac is still being pressurized, at least to some degree. And if it's still under pressure, it can continue to expand over time, which means it maintains that risk of rupture that the EVAR procedure was trying to eliminate in the first place.
Okay, that makes sense. So the leak bypasses the fix.
Right. And the critical and sometimes frustrating thing about endoleaks is that they're almost always completely asymptomatic. You wouldn't feel one developing. They're typically only detected through those regular scheduled follow-up imaging tests like CT scans or ultrasounds that happen after the procedure.
Okay, that's why the lifelong follow-up is so non-negotiable for EVR. You have to actively look for these silent leaks.
Exactly. That lifelong surveillance plan, typically involving scans soon after the procedure, maybe around 1 month, then at 6 months, and then usually every 6 to 12 months for life, is absolutely essential after EVA. It's needed to monitor for endoleaks, to check if the stent graft has shifted out of position, which is called migration, or to see if the aneurysm sac itself is expanding despite the repair. Open repair patients usually need less intense long-term follow-up specifically for the graft, though they still need regular medical checks, of course.
Are all endoleaks the same?
No, there are different types mentioned. Type 2 is actually very common. That's leakage coming backwards into the sac from small side branches, like lumbar arteries. These often resolve on their own without treatment. But other types, like type I, where the leak is at the top or bottom seal of the graft, or type 3, where the graft itself has a defect, usually require intervention to fix them and prevent sac expansion.
Okay, so whether someone is being watched with a small aneurysm or has had a repair, particularly EV, what does living with this condition or post-repair mean in terms of long-term care and patient teaching?
Well, risk factor modification remains absolutely critical, full stop. Whether you have a small AAA being observed or you've just had a big one repaired, quitting smoking is, hands down, the single most impactful thing you can possibly do for your vascular health.
Still number one.
Still number one. And aggressively managing blood pressure, cholesterol levels, and diabetes if you have it, that's also vital. It helps protect not just the repaired area, but your entire vascular system.
And for those being watched, the observation group.
Consistent follow-up imaging, usually ultrasound, as we said, is non-negotiable. You need to know if that aneurysm is growing, and if so, how fast, so you know when it hits that size threshold where intervention becomes necessary.
Okay. And after a repair, especially EVR, what's the long-term picture?
So there's the initial recovery period, of course. Gradual return to normal activities, probably avoiding heavy lifting for a while, standard incision care. But the absolute cornerstone of long-term care after EVAR is that lifelong imaging follow-up we just hammered home. Those scans at prescribed intervals, maybe 1 month, 6 months, then typically every 6 to 12 months for the rest of your life, are vital. Absolutely vital to ensure the repair is holding, there are no silent endoleaks developing, the graft hasn't moved, and the sac isn't expanding.
And open repair follow-up is less intense on the imaging side.
Generally, yes, for the graft itself. Once the initial postoperative period is over and healing is confirmed, the open graft is usually very stable. But patients still need ongoing medical care and checks for overall vascular health.
Are there specific warning signs someone should never ignore after any kind of repair, open, or EVR? Things they need to call the doctor about immediately?
Yes, definitely. Any new or sudden onset of severe abdominal or back pain could be serious. Unexplained fever could signal infection. Any significant changes around the incision sites, like increasing redness, swelling, warmth, or drainage, or importantly, any sudden swelling, pain, numbness, or discoloration in the legs or feet could indicate a problem with blood flow, maybe a clot or graft blockage. Any of those need immediate medical attention.
Okay. And because having one aneurysm increases the risk of others, that's part of long-term care too.
Exactly. It's important for patients and their doctors to be aware that they're at increased risk of developing aneurysms in other locations, particularly, as we mentioned, in the thoracic aorta up in the chest. So ongoing vigilance and potentially periodic screening for that possibility might be part of their long-term health management too.
You know, this brings us back really nicely to that case study, AL. Her story seems to tie so many of these threads together. A 68-year-old former smoker, mild hypertension, and that really significant family history. Her aunt likely died from a rupture, maybe her mother too. And her 5.8 centimeter AAA was found how, incidentally, during a routine checkup, just palpating her abdomen, she had 0 symptoms.
Her situation is almost a textbook illustration. You see all those risk factors piling up: her age, her smoking history, the hypertension, and that very strong family history. It perfectly highlights how these are often found unexpectedly, precisely because they don't cause symptoms until it's potentially too late. And her size, 5.8 centimeters, put her squarely in that danger zone where rupture risk climbs dramatically.
Especially as a woman, maybe hitting that threshold slightly earlier.
Potentially, yes. That 5.8 centimeters is definitely concerning, possibly pushing towards that higher risk category sooner for her.
And the case study walks through her options clearly. Watching it wasn't really viable at her size, so it came down to open repair versus EVA.
Yes, it frames that critical decision point beautifully. Open repair offered that potential for long-term durability, maybe less follow-up burden, but came with the costs of major surgery, higher immediate risk, and longer recovery. EVAR offered a much less invasive path, quicker recovery, lower upfront operative risk. But the trade-off, the big one, is that absolute commitment to lifelong imaging follow-up to monitor for those potential leak complications like endoleaks.
The case also mentions, just briefly, potential post-operative issues to be aware of, like the small risk of bowel ischemia after open repair due to temporary blood flow changes, or something called post-implantation syndrome after EVAR, which sounds like a temporary flu-like reaction.
Right, those are less common but important potential complications mentioned that patients will be counseled about. The post-implantation syndrome after EVAR is thought to be an inflammatory response to the graft material. Usually it resolves on its own.
And of course, AL's big worry, threaded throughout, was about her children.
Which is completely understandable and absolutely validated by everything we've discussed about the strong familial risk. Knowing about her AAA means her relatives, particularly her male siblings and offspring, should absolutely be aware of and follow those specific screening guidelines we outlined.
So a one-time ultrasound for her sons starting maybe 55 or 60.
Exactly. It provides a direct, actionable step for her family's preventative health, stemming directly from her own diagnosis.
This deep dive has really, I think, laid bare both the dangers and the complexities, but also the crucial points around abdominal aortic aneurysms.
Yeah, I think we've seen that there are these potentially dangerous dilations, often lurking silently until potentially a catastrophic rupture. We've highlighted those strong links to smoking, getting older, high blood pressure, and powerfully family history.
And we really drilled down on size being the most important risk factor for that rupture and the stark, dramatic difference in outcome between an emergency rupture and finding and treating it electively beforehand.
Absolutely. And we walked through the main treatment options, the more traditional, bigger open surgery versus the increasingly common, less invasive EVAR, really emphasizing their distinct risks, their different recovery profiles, and especially that non-negotiable need for lifelong monitoring after EVAR to catch those silent but potentially serious complications like endoleaks.
And those specific screening guidelines based on age, smoking history, and family history are just such a critical, practical takeaway for anyone listening who might fit those categories or knows someone who does.
Definitely a key message.
So, considering how often these potentially catastrophic conditions are found incidentally, just by chance, without any symptoms, and the really dramatic difference in outcome when they are found and treated electively versus when they rupture, this deep dive really leaves us with an important question for you, the listener, to maybe ponder. How does knowing about silent but potentially life-threatening conditions like this change your own approach to preventative health? And maybe just as importantly, how does it influence the conversations you might have with your own family about their medical history?
It really underscores the immense value of being informed, being proactive, and having those sometimes difficult but vital family health conversations.